started. And I will be your facilitator today. So my name is Sabrina Wong. I want to start with the land acknowledgement and to say that I am here with you today on the unceded territory of the Squamish, Musqueam, and Tsleil-Waututh people here in Vancouver, British Columbia. And I have been learning about different traditional medicines and indigenous plants of the Coast Salish people here. And I am a keeper of one of the cedar trees, which is a very important indigenous plant here on the West Coast, and very grateful for the rain that we are having today. And I would encourage you to invite you to, you could put in the chat where you are sitting today and to acknowledge the land on which you sit. I wanted to, let's see, what did I want to do here? Also say that we are here today on behalf of the Canadian Primary Care Research Network, and we have established a learning series. And the CPCRN has a bunch of different activities where we would like to have different people collaborating on generating solution-focused innovations in primary healthcare delivery. And our membership includes researchers, clinicians, patients, and policymakers, and it is pan-Canadian, and it is located on all the different Indigenous lands and territories across Canada. The CPCRN is aiming to build a primary healthcare learning system across Canada, and the learning series is part of that. We're also trying to facilitate reach and adaptation of successful patient-oriented and primary care integrated innovations. And we are also trying to create sustainable partnerships with patient partners, policymakers, clinicians, researchers, students, and other sport entities, as well as Indigenous communities and organizations. So I want to welcome you to the learning series and introduce our speakers for today, which of course I have now lost the, here it is, too many clicks on the computer. So today we have Jennifer Rayner. She is the Director of Research and Policy at the Alliance for Healthier Communities located in Ontario. She is also a research professor at Western University and also an associate professor at the University of Toronto. We also have Info Begin. She is a member of the CPCRN Patient Advisory Council, a member of the Health Data Research Network, Public Advisory Council, as well as PAN and CDHE patient partner evaluators. Oh, and I see Terry there, and we also have Terry, who is the vice chair of the Client and Community Partners Committee with the Alliance for Healthier Communities. She is also an inclusive event planning and research professional and volunteer, as well as an advocate for housing and disability rights. So I will turn it over to Jennifer, Info, and Terry. Welcome,
Great.
and thank you for being with us.
Thanks so much, Sabrina. So we're going to get some slides up, but while that's happening, I'll just sort of talk about what we're going to be talking about essential learning health system structures within primary care. And I'll be talking about how we implemented them within the within the Alliance. But then Mifo and Terry are going to be talking about why this is so important for the folks we serve and how clients and patient partners can get involved. So if we go to the next slide. Our goals are pretty simple with this learning session. We just want to identify what those structures were that we put in place for our learning health system and how we implemented them. So pretty quick, but then also, do a deep dive into why this is important from the client and patient perspective. So if we go to the next slide, so what exactly is a learning health system? We hear this more and more. When I first started thinking about this in 2016, 2017, we weren't hearing nearly as much. And there's no single type of a learning health system, but rather all sorts of various manifestations of it. There are some commonalities though, and I think that's what you're going to be learning throughout these learning series. So generally, a learning health system seeks to utilize data, research, quality improvement, and client and provider participation to continually generate knowledge, improve care, and deliver value. So we landed on a fairly common definition from the Institute of Medicine, which was built in 2011, that describes a learning health system as science, informatics, incentives, and culture being aligned for continuous improvement and innovation. And you're going to hear about this a lot because, for us, it was really the culture. You're going to hear that we had a lot of the stuff of a learning health system, but it wasn't until we made this really deliberate shift with our culture that we actually changed things. So I'm going to turn it over to Mo, and she's going to talk about what we're actually trying to do with this learning health system, like what problem we're trying to solve and why this is important.
Okay, thank you, Jennifer.
Next slide.
So yeah, so what problem we're trying to solve? So Jennifer mentioned that one of the key components of a learning health system is data and research. But right now, we have a problem that research takes a long time from research to practice. It takes so long that, without incorporating research into the learning health system, really you kind of lose that insight of ensuring that, the learning health system uses the latest evidence from the research. So that's kind of one of the problems that we have, that it takes too long to incorporate research into practice. And also data that we collected is not being used to actually improve healthcare. I find that as a patient, right, in especially primary care, like we have lots of clinicians have their own different EMRs that are not interconnected. So it's very hard to use that data collectively to do some analysis and provide feedback that we can incorporate it into the learning health system for improvements. And
Right.
also, yeah, and also like patient data. I think patient engagement as well. It's kind of, we are doing lots of work into the patient reported into the patient into SPOR, like the patient-oriented research, right? So I think, for the learning health system as well, we need to provide that patient feedback into the system to really improve the patient needs and health outcomes. So I think those three problems are kind of what we're trying to solve right now.
Great, thanks. If we can go to the next slide, why is this important to the folks we serve?
Yeah, so for me, right, as a patient, right, really accessing the healthcare system is really to get better care, right? So by incorporating the learning health system, I think we can improve the health delivery that me as a patient, that's really what I'm looking for. And I also think that by learning health system, we kind of bring back that the human touch that I feel that's kind of really kind of fading from the healthcare system right now, right? So as a patient, I want to feel that the patient that I am getting is kind of like personalized to me. I have all my needs met. So I feel like by incorporating the learning health system, that's something that we can show improvement in that. And also, I think because of data, there's so much data that's being used in the learning health system. I think it can address some of the issues like health inequalities, right? By analyzing the data that we get, we can kind of look at the populations wide and see which populations needs the most care, and then we can kind of do some measures to address those. So that's why, as a patient, the learning health system is kind of the way to go for the future of delivering care.
Great, thanks so much. So we're going to go to the next slide, and I'm going to be talking about what we did within the Alliance for Healthier Communities and sort of the real transition we used to become a learning health system. But if we go to the next slide, you'll see that it's been a long journey. So I'm going to go back in time a little bit just because some of this, past history is super important. So we have about 120 members of our learning health system, and this includes community health centers, nurse practitioner-led clinics, Indigenous primary care organizations, and other community-governed primary care teams in Ontario. But if we go back pre-2000, and this is when I sort of started, I grew up in the community health center world. So when I first started at the CHC, there was 54 community health centers and everybody was doing their own thing. And there was this general belief that each CHC was so unique that they could not be measured. So if we go back in time to that point, the ministry, the Alliance, and community health centers all sponsored an evaluability assessment. And this was what was really important because they said, do these organizations have enough in common to be evaluated? And a key point to this is CHCs are a salary-based model. So we truly were invisible. There was no data collected, there was no billing, there was nothing about any of the folks that the providers that worked in CHCs. So what we did is we created a framework and a set of data standards back in 2000, as well as metrics that we used to really understand the work we were doing and the folks we served. And at that point, it was a really important point in our journey because we took control of our own data. And because we were invisible, it was like we were like the little train that could, we decided to not only take control of our data, but build a data warehouse. So at that time, if we fast forward a little bit, we used a shared EMR, we had common data support, we had common metrics, we had patient experience measures, and we built this data warehouse that would store all that data. Because remember, otherwise we were invisible. I then worked hard to get that data linked with administrative databases. We built a committee structure to help guide all that work. And they helped guide both the structural and the content and kind of provided the leadership that we needed. And, if we fast forward to today, and I'm going to sort of fill in the blanks in the meantime, but we've got this commitment to ongoing evaluation to ensure the learning health system continually improves. I've just provided a link because, this was a long journey and it was just a paper that we wrote that describes this journey. But if we go to the next slide, all of that sort of ancient history. And what happened in 2019 is, although we had so much accomplished, we had, shared data, we had a shared EMR, we had data standards, linked data, all of this great stuff, there was a sense that we could do more. The strong foundation had been built, but we were not as successful as we wanted to be. And what kind of took us to this impetus was one of the key activities we had prior to this is 4 roles that we referred to as decision support specialists. And I was one of those folks way back in time. And this role included performance measurement, management, data quality, to ensure the data was used for decision making. And this was hugely beneficial. But by 2019, we kept hearing from folks that they weren't getting as much bang for the buck for these positions. So what we decided to do was not focus on those positions per se, but reimagine our whole culture and sort of create a whole new way of learning. So if we go to the next slide, what we did at this point is we had a Reimagine Day. And this Reimagine Day was just trying to think about how we could move forward with the system of excellence for data, quality, and evaluation. We did not merely go into this day thinking we'd embrace a learning health system, but this is where we landed quite early. So what people described in our initial visioning was the ability to use data to drive decisions, to focus less on widgets and more on outcomes, to ensure outcomes such as patient-reported outcomes, costs, value, and more focus on qualitative data was really embedded in the work we did, and that all of this work resulted in improvements to the care we provided. We envisioned how socio-demographic and race-based data and other equity data could result in fewer health disparities, similar to what Mfo was talking about, and how we could champion this data through the integrated care teams beyond the Alliance. Now, some of this was very aspirational, and we still have a ways to go, but this got people really, really excited. And we started imagining, maybe we could be a learning health system. And how do we do this and what's missing? And, how would quality improvement and learning be part of our culture? And how could we embed this in our day-to-day? So everyone left feeling really excited. And this is where we had to sort of really, they said, Jen, okay, you need to figure this out. So we rolled up our sleeves and started figuring out where our gaps were and sort of what we were going to do in the next bit. So we go to the next slide. So I touched on this a little bit, but really our next steps were to reframe all of our work into what we considered a learning health system. So what would we expect to change if we started working towards kind of wearing the badge of a learning health system. What would happen as a result? What would be the outcomes? So again, we recognized we'd spent a significant amount of time and resources into integrating this comprehensive EMR. All of our providers and all of our sites were recording standardized data. So if you were a physician, a dietitian, or an outreach worker, all of you were collecting the same data. All of this data was extracted into the data warehouse. We linked this data for research, population health planning, reporting, and performance. But we wanted to make sure that this data was used to actually improve service delivery. So despite me doing a lot of reports, a lot of research, we couldn't pinpoint exactly how this was making a difference. So we knew we had some steps to go before we realized this full potential. So our goal, our sort of vision, was to merge healthcare delivery with research, data science, and quality improvement. Our learning health cycle begins and ends with clients. We knew those client-provider interactions were key with everything we do, and we really tried to aspire to be a continuous learning environment where quality outcomes and kind of efficiencies were built into everything we did. So we wanted to be able to ultimately point to how all of this work would lead to better outcomes, improved efficiencies, improved decision-making, and improved provider engagement. So we just really wanted to make sure that data and evidence were part of this learning and improvement cycle and that it was seamless. So the next slide's a bit busy, but it's important. And I'm going to spend some time on it because this is sort of where we started rolling up our sleeves. So we followed the SEC framework. You're going to see a lot of frameworks, and in the next learning series, you're going to be introduced to the framework that we've adopted as part of the Canadian Primary Care Research Network. And you're going to see a lot of similarities because there's a lot of components or assets that are really important for a learning health system. So we use this system, we use this framework by SEC, and they were part of a group called Geisinger in the US, and they operationalized the learning health system components within an integrated service delivery. So we use that framework. The one we've adopted for the Canadian Primary Care Research Network wasn't built yet, but this one was really useful for us to kind of take an inventory of what we had. So first off, you need data. So we thought, okay, check. We've got data standards, we've got a shared EMR, we've got a data warehouse, and we've got the ability to link data within all of our administrative databases. The second most important thing is you need people and partners. Well, we had academic partnerships with every university in Ontario, and we had a team at the Alliance that could do this work that was led by myself. But we had some big gaps identified here. We didn't have great clinical engagement. So I think we were doing this despite our clinicians all working super hard at our sites, and we didn't have QI, quality improvement support. We were sort of giving people this data and it was landing on someone's desk with no support or tools and able to action or improve. The third piece was patient engagement. So within all of our member sites, they all have amazing patient engagement. Many of them are community governed. They're run by the patients they serve. But at our PBLN level, at the provincial level, this was a huge gap. So although we had such strong community engagement at the centers, we had literally nothing at the provincial level. It's a huge gap. 5, evaluation. We felt we were pretty nimble, we were responsive. We tried to do evaluations based on what folks wanted us to do, and we built in an ongoing evaluation as part of our learning health system. 6, the deliverables. So we had lots and lots of research. Like right now, we're involved in 32 different research projects. We had lots and lots of data. But again, the gap we identified was how much of that data and research was actually going back to the center to improve care. And how much of that reporting was actually useful for the folks that were reading it. So one of our key goals was to have more tailored reporting. 7th asset is prioritization. So how do you prioritize everything? We had pretty good committee structure. We had leadership. We had an executive committee that was appointed by our members to help guide this work. So we felt that was pretty good. 8 is organization. We had, again, strong leadership and sector endorsement. So again, we felt pretty good. We had, my CEO at the time was gung-ho to make sure this happened. Funding. Now, funding was something that we're going to talk about a little bit, because we'd put all of our energy and funding into the more technical side of things. So we weren't funding anything related to the actual use of data. And this is where we made a real shift. So we did have funding through partnerships, research dollars. We had these 4 positions. And so what we decided to do was retrain those 4 positions into quality improvement coaches, because we didn't have a magic pot of money. We just had to use it differently. So as you can imagine, like we're thinking we're pretty good. We've got these, this expert Geisinger told us these were the attributes you needed to be a learning health system. We had check marks at quite a few of them. But if we go to the next slide, we really didn't feel like we could make wear the badge. We felt, despite these assets, we really needed to focus on the identified gaps, because we felt this was what the main stumbling blocks were that were preventing us from closing the loop and actually, improving care. So what we needed to focus on was how were we going to better engage clients and patients at the sector level. And Terry can talk about that. She's part of our client and community research partners. We needed to get the folks that were doing the work better involved. So we had, again, tons of research projects, but I'd say we were really failing on having that improve, providers and staff engagement at the sector level. Quality improvement. Every center was doing little bits of quality improvement, but we were not facilitating that through our learning health system. And the tailored reports. So we were sending out lots of reports, but I'm not sure how meaningful they were when they landed on everyone's desk. So if we go to the next slide, this is what we ended up with, sort of our plan. So at the end of the year, we took 1 whole year to do this work. I mean, it seems like a lot of time, but we wanted to ensure we had lots of engagement and lots of consultation. So everyone, all of our members could really feel they owned this learning health system. So by the end, we had full endorsement, adoption, and support for our transition to a learning health system. And we did this really deliberately to ensure that all of the organizations could kind of formally sign on to embrace this shift. So we were fondly refer to our learning health system as EPIC, Equity, Performance, Improvement, and Change. And all of these activities within our learning health system are enabled by all those assets and components we just discussed. It's an active framework that continually results in improvement and action. So although learning health systems, like we talked about earlier, can take many different forms, a lot follow the same cycle. So you assemble and analyze data, you interpret that data. And when I talk about data, it's EMR data, research data, patient-reported experience data, patient-reported outcome data. And then you ensure that that data, results, and evidence are fed back into practice where change and improvements can occur. So this is our cycle of a learning health system. So we adopted this, the left side, the picture of the red and blue from Charles Friedman. He was one of the original learning health system gurus, and then we slightly adapted it. So the first image is from his work. And so the blue side involves sort of the technology and the data. It includes stuff like data standards, data collection, data assembly. And the red side involves the use of data. And this includes activities such as interpretation, meaningful feedback, and again, that improvement, as well as improved decision-making. And so, as you can probably figure out, most of our work up until the point of our learning health system transition had been focused on the blue side. We had strong data, we had strong data rules, we had strong data quality. But we really needed to focus our work on completing the red side. And this is what we refer to as closing the loop. So we recreated the image on the right just to make sure that every action was informed by the other. So this was really important because we wanted to make sure that data was informed by research and that all of the data continually improved and cycled through, and everything led to improvement. So again, you'll hear all of the centers talking about closing the loop, and they hold me to it. How are we going to close the loop? So if we go to the next slide, I thought I'd just give you some examples of what we're doing to sort of make this real. So the next slide. So what we're doing now is I sort of made a promise to folks that, no longer would you just receive a report from us, that the reports are going to be meaningful and they're going to be tailored. So what this means is we've created stuff like a primary care dashboard. And the primary care dashboard, depending on who you are, you can drill down to various levels to actually result in action. So you can identify who the clients are who haven't received a type of service and have the information to be able to contact those folks. We have a socio-demographic placemat that allows you to compare yourself to a bunch of other providers and organizations. We've got benchmarking reports, we've got peer groups, we've got all sorts of reports that are sent out to folks, but they're meaningfully tailored so you can action them. We've got standardized EMR data, we've got prems and proms. Again, everything is shared and comparable across all our organizations. We try to do really pragmatic research. And I think some examples of this where people were actually calling us asking, can you do, we've noticed this trend. Can you actually do a quick study to see if this is true and how we can actually use this information to improve our work moving forward? We've done some work with artificial intelligence using our EMR data to predict and identify people at risk. Again, we've linked all of our EMR data and we've got some really interesting tools, again, that are comparable across all the organizations to demonstrate the patient journey. So this is looking at, care from intake through primary care, through the overall health system, and then back into primary care. We've looked at COPD, mental health and addictions, as well as the overall healthcare system. And, you can identify gaps and again, improve care. One other thing I'm going to spend a bit of time with is we've built learning collaboratives. And this has been one of the most key things we've done, as well as rapid action learning intensives and communities of practice. All of this is to ensure we've got continual knowledge sharing and we can continue to learn from each other. Ultimately, we also evaluate our learning health system because we want to make sure we're actually making a difference. We want to make sure we can iteratively improve. Like we're expecting all of our sites to do this. How do we make sure we're doing it as well? So we want to make sure we're on continually improving our learning health system work. I've put a link to our website where there's tons of information, and you can also sign up for Epic News, which is our newsletter that includes all sorts of this work, but also highlights work from all sorts of other people. So, if you want something highlighted in Epic News that you're working on, we'd happy to be able to share your stuff, because that's what this is all about, learning from each other. So just quickly, I've only got a few more slides. I wanted to focus a little bit on the learning collaborative because this was the biggest shift we made. Remember, we retrained our decision support folks to be QI coaches. So now we needed to use our EMR data for improvement based on priorities identified by the organizations and the folks we served. So just quickly, a learning collaborative is a short-term learning system that brings people together from multiple organizations to seek improvement. We use the IHI's collaborative model for achieving improvement, and we combined, it was pretty formal, we combined didactic learning sessions and application through these phases. And so this is different than a community of practice, which we also have, which is much more structured and includes learning sessions, sharing sessions, and QI coaching. So next slide. So the objectives, we've had 3 so far. We want to improve outcomes in the area of focus, but I think almost more importantly, we want to build centers' QI muscle. So again, we teach people QI methods and tools, and we really increase the capability to do QI. This has been a key part of what we want to do, because again, that muscle will help people in the future. And we want to continue, we felt this was so key to our ongoing maturation of a sector to a learning health system. So just quickly, next slide, I'm going to talk about just the first learning collaborative we did. It was on cancer screening. We started this in 2021, and we had 14 teams participating. If we fast forward now to our third learning collaborative, I'd say almost 50 to 60% of all of our organizations have participated in a learning collaborative. We have 3 didactic learning sessions and 3 action phases to apply the concepts. We have a sharing session, and now we've developed more sharing sessions because people love to learn from others. And then we have a big capstone event, a big party to celebrate and hear about how the difference we've made. Every team is supported by a QI coach, and every team uses data from our data warehouse to provide data to teams monthly in the forms of run charts. Now they can also get this data from their EMR, which some teams are deciding to do. So they're using their EMR, and that's supported by us as well to help them get the data in a run chart format. So just quickly, run charts on the next slide. We don't need to spend much time, but you can see that this is just pre-pandemic. The reason we chose cancer screening is because it was identified by our providers as being a key thing that they needed to focus on, but also policymakers. Policymakers had identified that cancer screening, there was a huge backlog due to COVID. So we tried to kind of meet the needs of all of the different stakeholders. So you can see that everybody had fallen down below the pandemic median or pre-COVID. And then as soon as the Learning Collaborative started, improvement was rapid and it stuck. And I think that's pretty key. So the next slide just shows you the overall completion and how folks, you can see the difference between folks that participated in the Learning Collaborative, which is the blue line, and the orange line for folks that did not participate in the Learning Collaborative. And I think, when you look at the data now, the teams from the Learning Collaborative, and all teams have really improved cancer screening, but the Learning Collaborative teams are well over 80% now. So the next slide is just, we've done 3 Learning Collaboratives. Like I said, one's very much underway right now. The first Learning Collaborative was on cancer screening. The second one was the collection and use of sociodemographic data for health equity. And the third one is all about access and efficiency. That one's underway now, and it's hard. People are, it's really hard, especially in terms of the HHR crisis we're all going through right now. A couple of kind of foundational pieces is the quality improvement is evidence-based. We always need data. Data is always needed to answer the question, are the changes we're making resulting in improvement? Some principles: we use data for learning, not judgment. We seek learning, not perfection. So it's different than research. And we collect data frequently over time. And we're just really trying to implement behavior change to transform practice. And that's that whole culture piece. So if we go to the next slide, I actually took this slide from one of our sites. They said they have adopted this mantra, and I just love it. Care is better tomorrow because we learned from today. And I would say we do that by ensuring best practice knowledge is immediately available to support decisions, that improvement is continuous through ongoing learning, that it happens routinely, economically, and hopefully invisibly, and that it just becomes part of the culture. So that's our goal. If we go to the next slide, I just wanted to leave you with this quote, because, a revolution doesn't happen when society adopts new tools. It happens when society adopts new behaviors. And I think, if you go back to that toolkit, if you go back to that suitcase, we had a lot of the assets, we had a lot of the tools, we had a lot of the components. But until we really focused on how we could actually help support behavior change and change the culture, I'd say we hadn't accomplished our goal. We're there, we're getting there, but we need to continually support and change and that culture. So Sabrina, we've got hopefully enough time for some good questions, and over to you.
Great, thank you so much. So I'm going to open it up now for questions. Feel free to put them in the chat and discussion. And so I'll just start out, but you can also raise your hand as well. So I'll just get us started. I'm going to call on Terry. And I just wondered if you would be able to speak to how do you see where the Alliance is involving patients, and what could they be doing better?
Hi, thank you for asking. The Alliance and partners have been bringing research projects to the committee I'm on to basically suss out, for lack of a better word, whether their question sets are good and other aspects of other projects to see our take on it. Like anything else, there could be more diversity on our committee. And there's never enough time to fully analyze each thing because we only have a certain amount of time. And most of us on the committee I'm on anyway are very interested in the projects and could probably take 6 hours when we only have perhaps half an hour to look at it. So there's
Yeah.
always need, there's, as everybody here probably knows, there's always a need for more resources and more time, and that's infinite. One thing I actually think, a pet peeve I've had in many things, I've been a social justice advocate for most of my life, is the one thing that researchers and people planning out don't analyze is the cost of not doing this. Like, yes, there's a cost for this project, but projecting the cost if you don't do it my way, the way I want. Like if you don't if you don't try and feed people healthy food or whatever the item is, what's the projected cost? Because I found in most things, I've been anti-poverty, anti-homelessness, and homelessness is a healthcare issue. Instead of putting people in shelters and the resources needed for that cost more money that would to give people housing. That's just one example, and that's a healthcare issue because that doesn't even look into the healthcare aspects of keeping people precariously housed.
That's
Sorry for
great.
that.
Thank you.
Yeah, thank you.
Thank you, Terry. That's great. And hopefully, Jen, you all are collecting data on housing because I think that sounds important. But Info, I just wanted to give you a chance to also respond to that same question, and then we'll move on to Dale, who has a question.
I think as a patient, right, I think for a learning health system, we do need to be involved in the decision making. And one aspect I see, I talked earlier about patient engagement and feedback. So I think one area we can be involved in is kind of looking at PROM and patient-reported experience data and outcome data, just to kind of provide feedback on that, what kind of data to collect, how it's going to be used in the learning health system. And really, yeah, kind of, that whole experience of, as a patient, if I'm coming to the health system, I'm not just worried about, what kind of treatment I'm going to get, right? And I'm also worried about the whole experience, like the communication that I receive, interacting with the healthcare professionals, like how they're treating me. Are they treating me as an individual, or they just looking at me, oh yeah, this is just a disease we're going to treat, but not looking at me as a whole person. I think that kind of data, we can provide input and what kind of data to collect, how it's going to be used in the health learning system as well.
Well, that's great. Thank you. Thank you for your reflections, both of you. Dale, over to you.
Sorry, I'm just taking myself off mute and I'll lower my hand. First of all, thank you, Info and Jen, for the presentation. Jen, it's nice to see you. I had maybe a two-part question. The first one is following Terry's great question about kind of demonstrating value with decision makers. So, I mean, Jen, I would love to hear, sometimes I guess I'll start to say, is sometimes it's hard to demonstrate the value of doing something different when a funding model is already established and it's kind of baked into the operational model of a large organization. So A is like, how do you articulate the value in investing in kind of these types of more innovative projects to really fundamentally create change and to improve performance? And then just building on that question, part two is, I know that especially what's being done in the Alliance is really interesting, and that you were able to leverage the EMR data sets. I have heard that with some organizations maybe working with older EMR data or operating systems, that it might be difficult to kind of pull the information and act on it in real time, which I think is pretty critical to this model. So I was just wondering, is that a barrier, and is that, how would you kind of overcome that barrier? Thank you.
So I'll answer your first question. I mean, and others, please jump in. I think the older EMR systems would definitely be a barrier, but I think we've also got systems like SIPSN, or within Ontario, we've got Poplar, but that feeds into SIPSN. And what we're trying to do with SIPSN is, I mean, it won't ever be real time. So I think we need to kind of figure that out. But, you know, with something like SIPSN, where we're trying to build primary care dashboards, use the data for improvement, you know, use it for research, link the data, I feel like we can at least help fill the gap. And so if people don't know about SIPSN, you know, please, you know, contact us and we can get you hooked up, because what that does is takes the EMR data through all the proper permissions and then enables it for research and quality improvement. So that would be a huge step forward. You know, I think we've worked really hard with the Alliance to make the EMR, all the tools we develop in the EMR are available for everybody. So we work with TELUS, not that I'm supporting TELUS, but, you know, Practice Solutions, but all of what we've done is available for everybody. So I don't know if that's useful for anybody, but anything, you know, all of our tools are available. And what's sort of interesting with me is the learning health system is getting legs. And so I feel like, you know, in Ontario, we've got team expansion. Well, guess what is being seen as foundational? Developing a learning health system. So I feel like it feels like policymakers are realizing that you need to actually provide meaningful data. You need to have quality improvement coaches. You need to have facilitators that will help change the way you work in order to make it. It's not going to be magic. Like, you can't just give people information and hope they'll change. You need to actually support that. And I'm seeing that, you know, we've got two big things going on in Ontario with the Ontario Health Teams and the new team expansion, and both have said that learning health systems were important. So I feel like people are getting it. We have to enable it, and I think some of the work we're doing with CPCRN is going to really help, because there's a whack of practice-based research and learning network models throughout in Canada, and we're all on this journey of building a learning health system. So the more we can learn from each other, the more we can ensure that the practices we support can actually impact change. So I feel like we're all on the same wheel, trying to, you know, get to this good end result where we're impacting care. Just some of us are at different levels of, you know, a lot different stops along the journey. Sabrina, did you want to jump in?
No, I think that's good. I don't know, Terry, did you want to add? I thought I saw you come off mute, and then we'll go to Chris.
Apologies. No, I was just trying to keep my dog quiet. My apologies.
Oh, no worries, no worries. We like dogs. Okay, Chris.
I do too, but when he decides to chime in on this, the other thing I didn't mention earlier this would be on is because of my health issues and the issues of some of the friends and volunteer colleagues I have. One thing I see with this, like knowing pretty much nothing about it because I come from a different angle, is perhaps this can catch the unicorns in patients, because I have a few friends, colleagues who their health situation is unusual, is not the usual pattern. And having, like, as a child, I went to a regular normal went to a regular normal doctor's office. They were either sole proprietor or whichever, make up with it just a small thing, where I've found going to health centers most of my life now, that when my children or someone else close to me who also went to a health center had a situation, I found that the health team could pull their network to get advice. I have a few examples in my family, but I've also seen it where, okay, I don't know how to handle this, but I have this network, and now what I'm hearing from this is that the network is wider, and perhaps there could be a clearinghouse of, this person has environmental sensitivities. This is what has worked. That hasn't worked. That type of thing.
No, that's great. Thank you. Thank you.
Thank you.
Chris?
Thanks, Sabrina, and thanks a lot, Jen, for it's nice to hear from you and hear what you've been up to. I guess thanks in particular as well for making the learning health system real. I think one of the issues that I've been trying to ask for when I hear about the learning health systems is practical examples of the health system. You know, we hear a lot about theoretical and conceptual advantages of the health system, but how do you actually turn that into a tool that's used in practice? And so thank you for that. The question I have is whether you can think of examples that allow clinicians to deliver care to more people. So I see a bigger issue now. I feel like a lot of the examples of what we see in the learning health system and EMR tools, whatever they might be, helps us to increase screening. It's indicated, don't get me wrong, it's the right thing to do, but I see a greater issue now with access to care and the 20% of people or whatever it is across different provinces that don't have access to care. And so I'm wondering if there are any learning health system tools that improve, make it easier for us to provide the current level of care and therefore allow us to deliver more care. If you can think of examples off the top of your head.
Well, I mean, it's sort of our third learning collaborative, what we're really grappling with right now. So hopefully we get some really great lessons learned from there's like over 20 sites participating in this learning collaborative. What they're doing is so like each team picks a specific way they want to focus. So some people are working with scope of practice. So I know community health centers are lucky in the sense they've got big teams. So they want to ensure everyone's working to their very fullest scope of practice. And if they're not, what can they do to change that? Some people are working with the way they schedule well baby visits, or like, just like little tiny things to open up time in their schedule. Some people are trying to streamline the intake process. So they're implementing group medical visits. So they're working with teams to, their clinicians said some of the hardest parts of getting folks into the office to see new patients is getting the chart ready. So what they're doing is they're having people go through a series of group medical visits with a nurse practitioner, a pharmacist, and a nurse to make sure they get all that stuff organized. And then they're, when they get to the physician and nurse practitioner, they're fully kind of organized. So there's a whole bunch of stuff that's being rapidly tested right now. And every team, it feels like, is making success. And what we do is we share like kind of relentlessly. So like, I'm happy to share all of those results with you when we're done. But I mean, that's exactly what we're trying to do right now. We've got a bunch of teams, that are being kind of encouraged to do this by the policymakers as well. So it's a double-edged sword from both ends. We're trying to do it from the policy side because we've got all these unattached folks, but also from the provider side, just needing to make their schedules more efficient. So yeah, lots of examples. And I think every team with their QI coach is making a difference. Like every team seems to be succeeding in what they're doing.
Yeah, a lot of it comes down to having a QI coach who can
exactly
push that along. Is that a critical part? Yeah. Thank you.
No, that's great. Sort of a follow-up question, and then Joseph. So how do you choose your learning collaboratives? Because it sounds like you could do one kind of cycle per year, but how do you choose those? We have multiple organizations.
We have multiple organizations, and we have this leadership structure that helps us choose it. And they take into sort of like the learning health system team kind of talks to patients, but also providers. But we also look at what's sort of on the policy agenda. So we knew like the HHR crisis was causing a great deal of hardship for everybody. So that was why we chose our third learning collaborative. The first one was the cancer screening because we knew there was this huge backlog. So we sort of do kind of an environmental scan of what's going on and make sure it resonates with our executive leadership. That were chosen, so our executive leadership was chosen by the sector to they've been given the authority to make decisions on behalf of everybody.
Yeah. Okay, that's great. Joe.
Yeah, thank you so much, Sabrina. Thanks, Jen and for the great presentation. I'm really, a fan of your approach, especially with this learning collaborative and how it's kind of evolved into what a working example of how we can kind of start to see learning health systems really play out in practice. And You're definitely leading the way in that, so I appreciate all your work. I'm wondering about the role of the QI coach. You talked about retraining people into those roles. And I guess my question is, what was that process like? What kinds of training did that involve? How did these individuals, I guess, because there's, I suppose, a confidence that comes with trying to navigate supporting all of these clinics and giving them what they need without just, facilitating a meeting. So yeah, I'm curious about that. Thanks.
So I did it really deliberately. So what I did is I worked hand in hand with this QI guru, Lori Zagar. So a lot of people know her. She's worked across Canada. So Lori Zagar and I did a lot of this work together. She was my QI guru, and I knew that the four people needed to be retrained. So they did IHI training. They did, kind of the didactic stuff. But what we did is we set up weekly coaching meetings with Lori. And so Lori helped coach the coaches. And the way we did the first learning collaborative was Lori ran the show. Like, she did everything. She did all the coaching of the teams. And the way it worked was the 4 people shadowed her. So they went to all of the coaching sessions. They went to the didactic sessions. They did all of they really shadowed Lori. The second learning collaborative, again, very deliberately, long-term plan was planned that they would then lead, but Lori would be totally there supporting them. So, if they couldn't do it, if they ran into problems, and we still had those weekly coaching meetings, which were super helpful because they could say, oh my goodness, I ran into this issue. What do I do? And Lori was there supporting them. So that was the plan, kind of it was like a long period, like everything's a long journey. So it was like a 2-year plan to kind of get folks to feel comfortable to be able to do it on their own.
Great, thank you so much.
And the other thing is we've got something that we've created. So myself and Quebec and Manitoba, we're talking about coaches and we wanted to learn from other coaches. We've started this thing called the Coaches Corner, and each coach, I've been sort of facilitating this, and the coaches all join and they share case studies once a month so they can learn from each other. Like, Quebec and Manitoba are also doing amazing work. I'm sure there's people from all across Canada doing amazing work. And so this Coaches Corner, I think it's every 2 months, actually, not every month, but we're presenting cases and actually learning from each other. So let me know if you want to get involved.
Yeah, I'll likely be in touch. Thank you.
That's great. Any more questions or comments? Jennifer.
Hi, everyone. Thanks, Jen, for your presentation and everyone's thoughtful questions. I have a question in the realm of back to sort of the culture and rules and things that really make the learning health system thrive. And sort of the special positioning of the Alliance as a community, very entrenched community health member and service provider, and just really embedded in communities. There's other primary care has strong footing in academic departments of family medicine. And then there's another array, as we know, that's community-based and neither with the Alliance or affiliated with academic family medicine and other models beyond, I'm sure, across Canada that I don't even fully know about. So how can these other models pick up just a few pointers from the culture base that the Alliance and EPIC have formed to be so successful? And what are some of the key things that are both feasible, like within reach for these other models?
I think a couple things. I think, what can practice-based research and learning networks do for those practices is another way to frame it that might be better. Because I think, how do we give people meaningful data to actually impact change? Like, I think giving a solo practice a deep, dense report is probably meaningless. Like no one will ever do anything with it. So I think that's sort of a key thing. How can we, that's maybe a carrot. How do we give people meaningful data that they can think, oh, wow, I need to do something? Because I think in everyone's hearts, they want to provide the best care. So I think how can we tailor data and make it meaningful? I think, you know, if we could give people some quick QI training, you know, I know this fellow Daniel, he's a solo doc, or he works in a team, not a big team, with 3 other physicians. He's testing something right now, and it's just with some QI skills that he's doing this. If we could, he's just interested, keen, curious, and innovative. So how do we give people some QI skills to be able to understand if that's making a difference? I think would be a great win for everybody, because they've got good ideas. We just need to make sure it's actually making a difference. So I think we need to come up with some carrots as PBRLNs to actually, for people to see the value.
Yeah, no, that's great. Thank you. I want to thank Info, Terry, and Jennifer again for a great learning session. And I know that this sort of scratches the surface, but we'll be continuing to take up and learn from the Alliance and the work that has been going. So really want to thank you for joining today. And please do fill out the evaluation on your way out, because we really want to understand how we can make these sessions more meaningful to you as our community moving forward. So thank you, and thank you all for joining. Thank you.
Thanks, everybody.
Okay, bye.